So now let's move on to the diagnostically focused questions. So here you want to recognize the core diagnostic features, and the challenge with these diagnostically focused questions is, the DSM-5 has a lot of disorders, and each disorder has quite a few criteria. And it could be quite challenging to learn all of these criteria for all these disorders, especially for the disorders that you really don't treat. You may have low or zero familiarity with them. So there's a lot of verbiage in the DSM-5, which is kind of boilerplate. It's not very useful. So you need to learn to identify the core diagnostic features of each disorder and focus on those core diagnostic features. Of course, I'm going to give you examples for all of this. And then learn, in addition, the core distinguishing features between the disorder that you're studying and closely related disorders. So for example, as I'm going to present to you, you not only want to know the criteria for anorexia nervosa and bulimia nervosa and binge eating disorder, you need to know how they differ. Specifically, objectively, consciously. If I ask the question, tell me how bulimia differs from anorexia, you can just tell me without hemming and hawing and having to look things up. Because the vignette will be written in such a way, a recognized vignette will be written in such a way that it definitely moves you towards one disorder, but includes information that moves you away from another disorder. Just as we already saw in the first module, illness anxiety disorder, that this person presented, that man with the fears of stomach cancer denied having somatic symptoms, right? You can ignore a lot of the boilerplate criteria. Of course, every single disorder in the DSM-5 either has to cause distress or some degree of dysfunction, social, occupational, whatever kind of dysfunction, interpersonal dysfunction, because if it didn't, it wouldn't be a psychiatric disorder. And then identify the core symptoms, and I'm going to give you an example of ADHD, where there's a lot of verbiage, a lot of quote-unquote symptom criteria, but they're not really symptoms, they're just examples of a core symptom. All right, so let's move on to that soon. First, here are some additional active learning tips. Visualize a patient, if you've ever had one with a disorder that you're studying, visualize a patient with that disorder and pretend you're there in your, let's say in your office, and they're explaining to you all of their symptoms, right? And then imagine like, well, what symptoms do they have, and how long have they had them, and what kind of dysfunction do they have from it? And then you imagine yourself coming up with follow-up questions. And then you imagine observing them, what kind of mental status exam items are visually observable. Are there any motor symptoms, adventitious motor symptoms? Is there any change in interpersonal functioning and reactivity? Is there any difference in emotional responsiveness, things like that? So imagine this. Now, if you're reading a vignette on a disorder for which you've never had a patient to treat for that, just imagine, make one up, and imagine again that that patient is describing to you their disorder. It's very hard to read words on a page and really then be able to, in a way, incorporate them into your knowledge base in a way that will allow you to instantly recognize it when you read it in a vignette format, okay? There's a little bit of translation that has to occur from diagnostic criteria into recognition in a vignette, right? Those are the recognize it questions. So another tip is, I think we all spend a lot of time in our cars commuting and otherwise. So this is a good time to engage in those visualization of patients exercises, or imagining, patient that you've never had, but that you can imagine having, and then even speaking out loud and pretending you're interacting with them. Everyone talks in their cars now because we have hand-free phones, so it doesn't draw any attention if you're kind of talking out loud to yourself. So just keep that in mind in order to extend your study time. All right, so let's start with example 1. I have 4 different examples. Example 1, let's look at ADHD. So it's characterized diagnostically by a pattern of inattention and or hyperactivity-impulsivity lasting at least 6 months. Okay, 6 months, I want to note that. Several symptoms must be present before age 12. Okay, I want to note that. DSM-4, that was 7 years, but we don't care about that anymore. Now, probably most importantly so far is the next criterion. Several symptoms must be present in at least 2 settings: school, work, home, other settings, community, what have you. And the reason for this is because if those hyperactive, impulsive, or inattentive symptoms are present in only one scenario, maybe it's something specific to that setting or to that main individual in that setting, the teacher or a parent, or if it's happening in grandma's house, maybe something with grandma or about grandma. So, these symptoms have to be at least in 2 settings. And you can imagine, right, a vignette being written where it says that this child is quite impulsive and hyperactive, in certain class with one teacher, but then no other teachers, say, no, I don't see that. And parents say, well, I'm not surprised, I don't see that in my child at home. So that's a tip-off that they're leading you away from ADHD, right? Now, the symptoms interfere with or reduce quality of social, academic, or occupational functioning. Sure, kind of boilerplate. Not better explained by oppositional or defiant behavior. Interesting why they put that in there. The reason is because there's overlap, right? A lot of kids with ADHD, since they're having trouble really, controlling their behavior in a way that will be congruent with the expectations of a setting, their behavior is kind of oppositional or defiant, or in some way kind of not cooperative. So that must be distinguished. So now let's look at more detail into the inattention symptoms. And my gosh, look at this. There's 9 inattention symptoms. But that's not really true. This is just examples of inattention. Often fails to give close attention to details or makes careless mistakes. Often has difficulty sustaining attention, seems not to listen, difficulties organizing tasks or activities, avoids or dislikes tasks that require sustained mental effort, does not follow through with instructions, and fails to finish work or chores, loses needed things, often forgetful and distracted by extraneous stimuli. Again, just examples of inattention, right? Do you really need to memorize each of these? No, it's pretty like explanatory after you're like, okay, these are just examples of inattention. Same thing with hyperactivity-impulsivity. Often fidgets, leaves seat when being seated as expected, often rhymes or climbs excessively, has difficulty playing or engaging in leisure activities quietly, on the go as if driven by a motor, talks excessively, blurts out questions, has difficulty waiting their turn, interrupts or intrudes on others. Again, just examples of hyperactivity-impulsivity. So specifiers, so you can have predominantly the inattentive type or the hyperactive impulsive type, or combined, and then you can have mild, moderate, severe, and just note that ADHD can be in partial remission. All right, so you notice how you can take a huge amount of data there and kind of like, hey, this isn't that hard, right? There's not that much to ADHD, even if you don't treat it, there's not much to it. All right, now let's look at somatic symptom disorder, because this is an area where the somatic symptoms can seem confusing and overlapping and hard to distinguish. So let's look at the criteria. So somatic symptom disorder is characterized by 1 or more somatic symptoms that are distressing or disruptive to daily life. Okay, so I need at least 1 somatic symptom. What the heck is a somatic symptom? Well, frankly, the easiest way to remember is to replace the word somatic with physical, a physical symptom. Pain, indigestion, bloating, diarrhea, constipation, pain during sexual activity, just things like that, physical symptoms. But in addition, you also need excessive thoughts, feelings, or behaviors related to the somatic symptoms or health concerns, and it has to be evidenced by 1 or more of the following 3. Disproportionate and persistent thoughts about the seriousness of the symptoms. Notice that, wow, that overlaps with illness anxiety disorder. Persistently high level of anxiety about health or symptoms. Hey, that overlaps with illness anxiety disorder too. excessive time and energy devoted to these symptoms or health concerns. Well, that also oftentimes overlaps with illness anxiety disorder. So what makes somatic symptom disorder different from illness anxiety disorder? It's the first criterion. You have to have a somatic symptom. And illness anxiety disorder has to exclude the possibility of a somatic symptom. Now, you can have very mild ones or fleeting. You know, that's okay. There's gray areas, but your vignette's going to make it clear it should be one or the other. You just have to recognize, really, that somatic symptom disorder has these two symptoms, really, a somatic symptom and then some concern about it, typically 6 months or longer. Diagnostic specifiers, just know that there's, when that's with predominant pain, the main somatic symptom is going to be one or more different types of pain, right? And now let's look at illness anxiety disorder. So there's preoccupation with having or acquiring a serious illness. Again, that could overlap with somatic symptom disorder. Performance of excessive health-related behaviors. Again, that could overlap with that too. But now the third one, somatic symptoms are not present or are mild. So that's the main distinguisher, right? Preoccupation, but without pain, numbness, dizziness, etc. And if a medical condition is present, because it can be, then the patient's concerns are excessive to that condition. And then you want to specify if it's care-seeking type or care-avoidant type. So some people with illness anxiety are actually so deathly afraid of their worst fears being confirmed through a medical workup that they actually avoid seeing doctors and other clinicians. So when we put this in a little table, then this is what we get. So you see we have somatic symptom disorder, conversion disorder, illness anxiety disorder. So somatic symptom disorder and conversion disorder both have somatic symptoms. Now conversion disorder, it's usually pretty easy to distinguish from somatic symptom disorder because it's going to be pseudoneurological. Again, some sort of disturbance in motor function or in sensory function, right? And usually that person, although the criteria don't say anything about it one way or another, the person with conversion disorder is not going to have excessive concern. In fact, they might kind of show this kind of like beautiful indifference, as they say. The main distinguisher, though, between those disorders and illness anxiety is that illness anxiety specifically excludes the presence of a somatic symptom, right? Unless, again, it's fleeting or mild. But again, we don't have to worry about that. So in the first module, I shared with you a vignette of illness anxiety disorder. So now let's look at one that would, kind of a prototypical vignette that describes somatic symptom disorder. A 38-year-old woman presents to the emergency department with a chief complaint of, "My awful pain is worse again." She has had 43 previous emergency department visits for similar pain complaints in her, quote, shoulders, back, pelvis, and thighs. She has been hospitalized twice for suicidal ideation and has a diagnosis of major depression and dependent personality disorder. She endorses a mutually abusive relationship with her husband, with whom she often drinks alcohol together as, quote, our way of socializing. Her previous workups for pain have yielded a diagnosis of musculoskeletal pain, and she has been referred to physical therapy. What's her most likely diagnosis? And by the way, clearly, you look at the options, it doesn't ask you about dependent personality or major depression, right? So you're going to choose the one out of the options presented. Is it body dysmorphic disorder, conversion disorder, adjustment disorder, illness anxiety disorder? No, it's going to be somatic symptom disorder, right? Again, this is a vignette that includes a lot of other information. It kind of gives you paints a word painting picture, but you know, a lot of the information is extraneous to what we're really being asked about. Now let's look at example 3. Diagnostic differences between eating disorders, because this is another one. In addition to somatic symptom disorders, this is another area that can cause even knowledgeable candidates to get the vignettes wrong diagnostically. So we have anorexia nervosa, bulimia nervosa, and binge eating disorder. So note that only one is characterized by abnormally low weight. In fact, you have to have abnormally low weight in order to have anorexia. If you have normal weight, if you're overweight or obese, it is not anorexia, right? While bulimia nervosa and binge eating disorder, it doesn't specifically mention being underweight, but it's pretty much if you're underweight, you're probably going to be anorexic, right? So we're looking at the core features here. We're not trying to kind of nitpick, but you know, bulimia nervosa, binge eating disorder, the person in that vignette will be of normal weight or higher. In a vignette, when the person is of low weight, it's going to be anorexia. So that's one thing right away you can distinguish anorexia from the other two. By the way, CDC says that the lower limit of normal weight is a BMI of 18.5. So anorexia is going to be anyone with a BMI of 18 and below. And somewhere like, let's say, I can't remember if 17, let's say 17 up to just below 18 and a half would be mild, and then below 17 would already be moderate and then more severe. So now let's look at the other part though. And this is very important for you to note too, because anorexia nervosa certainly can have binging behavior and also a lot of compensatory behaviors. Restriction is definitely required because you have to have low weight due to restriction, right? Restricting one's calories. But other than that, you don't need, you can have, but you don't need compensatory behaviors. So here's the secret. Bulimia nervosa, you need both binging behaviors and compensatory behaviors. But that does not distinguish bulimia from anorexia, because you can have those in anorexia too. Again, what's going to be the main distinguisher? The low weight in anorexia. By the way, since we're here, let's review the definitions. What are compensatory symptoms? They're purging behaviors, fasting, and excessive exercise, right? So anorexia does talk about fasting and abnormally low weight. And then, of course, purging behaviors include several different types. It's not just vomiting, although that's a common one, but also abuse of different substances in order to keep, to purge, right? To try to undo the binging. And that includes misuse of laxatives, of diuretics, and other medications such as thyroid medications like Synthroid, psychostimulants that can suppress appetite and lead to weight loss. So those are compensatory behaviors. Again, those do not distinguish, their presence does not distinguish anorexia from bulimia. All right, now let's look at the difference between bulimia and binge eating disorder. So they're both characterized by binging. So you have to have binging. Binging, by the way, can occur in all three. It may or may not occur in anorexia. It has to occur in bulimia, and it has to occur in binge eating. Then the difference, though, is that in bulimia, you have to have compensatory behaviors. In binge eating disorder, compensatory behaviors are excluded. They're not permitted, they're excluded, because if you have them, boom, the binge eating disorder is then re-diagnosed as bulimia nervosa. Okay? Last example, a little bit different. And this is just an example how you can take a huge amount of information and really try to summarize it to yourself. And again, you can speak this stuff out as you're driving. So this is the last slide in my neurocognitive disorders lecture, which is like 3.5 hours long. And this captures a substantial percentage of the knowledge that you have to have about neurocognitive disorders. Believe me, it's you want to go through the rest of the lecture too. It's not like it's useless, but this one slide captures a substantial percentage of testable material. So it's a clinical comparison of the neurocognitive disorder etiology. So for example, Alzheimer's disease, it's characterized by cortical deficits, social graces and executive function are maintained, and no focal neurological deficits are going to be present, or if they are, not prominent, right? Frontotemporal neurocognitive disorder, Disinhibition, apathy, dysexecutive syndrome, and or aphasia are going to be present. Lewy body disease, it usually presents with cortical deficits, fluctuating cognition, autonomic instability, motor symptoms, antipsychotic med sensitivity, and REM sleep behavior symptoms. And then that should be distinguished from neurocognitive disorder due to Parkinson's disease, where many of those same symptoms can occur, but the motor symptoms come first, at least a year before the cognitive symptoms. So it's sort of like neurocognitive symptoms occurring in well-established Parkinson's disease. So those are very closely related. Lewy body, neurocognitive disorder with Lewy bodies and neurocognitive disorder with Parkinson's disease really is on the same spectrum. They're both Lewy body diseases. It's just like the order in which symptoms occur, the motor symptoms occur. Vascular disease, the vignette is going to talk about focal neurological deficits, and note that the presentation could be either cortical or subcortical. So it could go either way, because you can have small vessel subcortical disease or large stroke, thrombotic strokes in the cortex, and have a cortical presentation. Now, if you have subcortical features, that could be due to vascular disease. It could be due to HIV, AIDS, dementia, Huntington's disease, normal pressure hydrocephalus, among others. And then classic Creutzfeldt-Jakob disease, it has a couple of pathognomonic findings, which would be included in your vignette. The EEG shows fast polyphasic waves, and when you do a lumbar puncture, the CSF will show evidence of a protein called 14-3-3 protein. So again, this is another kind of way where you can capture a lot of information as you're focused on these diagnostically focused questions. Again, just to highlight, most diagnostically focused questions will be actual vignettes. You're not going to be asked like, which of the following response options is a symptom criteria for somatic symptom disorder. So you're not being tested on criteria per se. You're tested on recognizing, a clinical vignette, a presentation, and saying, yes, this is most likely this disorder versus this other option or this other option. So again, the diagnostically focused questions in the standalone section, as well as the extended vignette section, will most likely be vignette-style questions. So that's it for me. You take care of yourself. See you back soon. Thanks a lot.